So this was supposed to be given by Dr. GC, so let me see how I can justify his talk. Critical steps for confirming angle closure disease. I think this is the most important one. So we should start with understanding how you define angle closure, what is very important with the history, starting from history evaluation, and how do you go ahead and diagnose. So like I said, it's very important to define them appropriately. What do you mean by a primary angle closure suspect, primary angle closure, and primary angle closure glaucoma? So once we are clear with this, I'm not going into the definitions, but once we are clear with this, I think the rest of the things will become very easy for us. When I say primary angle closure disease, that I'm going to refer to, that will include primary angle closure and primary angle closure glaucoma. Primary angle closure suspect is something that you know that you need to follow up, and maybe a small cohort of those patients may require treatment, but otherwise they are not clubbed into the primary angle closure disease. So also it's very important to identify the risk factor. Like I just said, all primary angle closure suspects you don't have to treat. Only 1 in 4 patients with primary angle closure suspect over the next 5 years when followed up meticulously may develop primary angle closure, and similar number also from PAC will develop into PACG, which means that 1 in every 4 patients in PAC, if you have done a YAG PI, maybe you will prevent an angle closure from developing, so which is very, very important as well. So those that have bilateral primary angle closure and those that have a primary angle closure post PI but continue to have elevated intraocular pressure, and those where the PI was not done in a primary angle closure, so all of these are primary angle closure. So PAC post PI but have elevated IOP, and those who did not have a PI are the ones who are going to progress faster. So I think it's extremely critical for us to identify these risk factors, and they need to be treated. Often angle closure glaucoma in India is asymptomatic. Very few acute angle closures we do see. We see a lot of chronic angle closure. We see a lot of acute on chronic angle closure. That means by the time they present to us as an acute angle closure, several of these patients can also have a disc damage, which means that it is not just this episode. Prior similar episodes would have happened in these patients as well. Meticulous anterior segment examination is extremely critical, and I think peripheral anterior chamber examination by a Van Herrick's test is something that can be done even in a center where you don't have any other devices available. So with a slit lamp examination, this cannot be an alternative to gonioscopy, but at least this can guide you as to in whom you need to do a gonioscope. So grade 1 and grade 2 Van Herrick's as compared, peripheral anterior chamber test as compared to the corneal thickness are considered narrow angles. They definitely require a gonioscopy. If it is possible, do it in everybody, but otherwise at least in these 2 grades we need to do. Very subtle and obvious anterior segment signs are something that we see in these patients. So you see some amount of sphincter atrophy, sometimes you see large areas of sphincter atrophy, and sometimes you see with acute angle closure, they can present with low IOP, especially if they've had high pressure, somebody has treated them, or because of high IOP and whatever medications they were given, they can go into a ciliary shutdown, so they can present with normal intraocular pressures also. So I think one needs to be aware of that. Asymmetrical pupil size in these patients when you have no other pathology is, unless proved otherwise, is possibly an angle closure where you have pupillary changes plus possibly the disc is also damaged in that eye. And always remember to rule out secondary causes associated with these conditions as well. Gonioscopy is most critical, all of us know. So for you to know whether there is angle closure or not, it is very critical. Also to understand whether this is occludable, whether there are synechiae and all of these, I think gonioscopy is very important. But apart from just doing a gonioscopy, which is indentation gonioscopy is something that most of us do, but you can do whichever gonioscope that you are comfortable with if you know what you are doing and how to identify the PACS, PAC and of course PAC, but PACG if you have disc changes. So what is important is to know 2 things. One is the angle occludable? And if the angle is occludable or open, so you have differentiated that, what other pathology is there in the angle? So for which you require both a darkroom examination as well as with a bright light illumination and an examination. So to identify whether this is occludable or not, a darkroom illumination, a thin slit beam and a narrow slit beam, which is the shorter slit beam that doesn't fall on the pupillary area, so that you don't cause the artificial angle opening by pupillary constriction is very, very important. But once you identify this, also it's very important to brighten the light to make a broader beam to understand what else is happening in the angle. That becomes critical. So I won't go into these details, but what is important is when you have an angle closure, if you use a mirror, if you use a lens, gonio lens, that has a higher mirror, and that the mirror that is closer to the center possibly will help you to give you a better view of the fundus, a better view of the angle structures. So where do you do it? In all those who has glaucoma or those who have a suspicion of glaucoma, they need to be done and also repeated in between whenever they come back, at least once in a year or every time when they have a elevated intraocular pressure. Understand what the normal structures are so that they know what the pathology looks like, and appropriate testing conditions are very important. So just to touch upon, sometimes you see pigmentation on the back of the cornea, which is like pigmentation of the Schwab's line, which may appear as if it is pigmented trabecular meshwork. But even then, if your anterior chamber is shallow, do an indentation and then you realize that you have another pigmental line that is there at the back, which tells you that primarily what you were seeing was not a open angle. Blotchy pigments are isolated, patchy pigmentation of the trabecular meshwork. They are a sign to say that there was a prolonged iridotrabecular contact, and that again is a sign of PAC, and that needs to be treated. Of course, you do see synechiae post-PI, identify whether there is plateauvirus or is there any other pathology, whether there is synechiae or pseudosynechiae, or you have sometimes can also visualize things that are structures that are abnormal under the iris. Role of imaging has very limited role, I would say, but then you realize in angle closure, apart from relative pupillary block, there are other mechanisms that are there like plateauvirus and increased lens vault. So we should be able to understand these underlying anatomical abnormality as well, and imaging definitely has a role in picking up these two. So imaging cannot replace gonioscopy, but it definitely can be used as an adjunct. And always remember, PACG can be a masquerade to glaucoma suspect and the normal tension glaucoma patients as well. So, yeah, so this is the last slide. So I would say that angle closure, while primary is most common, remember that there are young people who are presenting or those who present with unilateral angle closure. So you need to remember that there could be secondary causes that needs to be ruled out as well. That's all. Thank you.
Thank you, sir.